Hello, and thank you for your interest in this New Jersey nursing students' community health project. My name is Heather Foley, and I am the Community Health Director for NJNS for the 2013-2014 term. For the past year, it has been my mission to raise awareness on the greatest health threat women face today. But contrary to popular belief, I'm not referring to any kind of cancer. In fact, the subject of this video claims more lives than all forms of cancer combined. It may surprise you to hear that the #1 killer of women is heart disease, and that it kills more women with less warning than it does men. After watching this video, you will understand why this is the case, and you will be prepared to join the fight against female pattern heart disease. You will discover its subtle symptoms, understand its unique pathophysiology, and gain strategies for effective patient advocacy. You may have been under the assumption that heart disease is primarily a man's problem. While this is a common misconception among both lay people and the medical community, this stereotype is simply not true. The truth is, cardiovascular disease affects us all, and is the leading cause of death regardless of gender. However, since 1984, it has claimed the lives of more women than men every single year. In addition, compared with half of all men, a staggering 2/3 of women who experienced sudden cardiac death were previously asymptomatic. Because heart disease does not affect men and women equally, it is evident that there are some gender-specific differences at play. The question is, are these differences due to female physiology, practitioner prejudice, or some combination of these factors? During the course of this presentation, we will explore this question. But before we continue, I would like you to take a moment to think about all the women in your life. Realize that 1 in every 2 women will be impacted by cardiovascular disease. And realize that you, as a nurse, have the power to make a positive impact in the fight against heart disease for your loved ones, your patients, and yourself. As I mentioned before, heart disease was traditionally thought of as a man's disease. But when we take a look at the numbers, we can clearly see that this is not the case. In fact, in the mid-1980s, we can see that the female cardiovascular mortality rate overtook that of men. In the following years, we can see a dramatic increase in the gender disparity of cardiovascular mortality in a relatively short time frame. To put this in historical perspective, the drop in male heart disease mortality rates correlates with some important advances in interventional and therapeutic cardiology, such as the emergence of coronary angioplasty, the first stent placement, and increasing use of aspirin for patients with acute myocardial infarction, or AMI. These interventions certainly decreased cardiovascular mortality in men, but we don't see the same degree of improvement for women. In fact, the mortality rate for women increased dramatically during the early 90s. This was an alarming finding for those who realized this trend. In 1991, Dr. Bernadine Healy, the first female director of the National Institutes of Health, wrote an editorial demonstrating gender bias in the management of coronary heart disease. Dr. Healy found that women who were hospitalized for AMI were less likely to be referred for diagnostics and therapeutic management than men. At face value, this may look like practitioner prejudice, and that may indeed have been a factor. However, Dr. Healy also discovered that when women were found to have major blockages in their large coronary arteries, they were just as likely as men to receive life-saving revascularization, such as a stent or coronary artery bypass graft. This caused Dr. Healy to hypothesize that maybe there was a biologically based difference in male and female heart disease. Dr. Healy's findings catalyzed an investigation of gender differences in cardiovascular disease. These investigations included the Women's Health Initiative in 1991 and the Women's Ischemia Syndrome Evaluation, or the WISE, in 1996. Over the next 5 years, the gap in mortality between men and women only widened, but the WISE study was on the brink of a startling discovery. In 2001, the pilot phase of the WISE study was published. This study enrolled women who were suspected to have myocardial ischemia based on a history of both symptoms of angina and evidence of myocardial ischemia on non-invasive testing, such as ST elevations on an EKG. All of these women underwent coronary angiograms, and here's what they found. only 43% were found to have major obstruction in their coronary arteries, and those who did were likely to have disease in more than one artery or multi-vessel disease. It was obvious that they were suffering from coronary artery disease, so they were treated with the standard effective protocol of stenting and medications. However, the angiograms of the majority of the study participants did not show a major occlusion. In fact, many of them looked totally normal. Unfortunately, in the absence of a positive angiogram, these women were likely sent home without any further investigation or treatment. WISE study data soon revealed that such women who had normal angiograms despite their symptoms were still at significant risk for having an adverse cardiovascular event, such as myocardial infarction or sudden cardiac death. In other words, if a patient who presents with unstable angina has a negative coronary angiogram, it does not mean that she does not have heart disease. In later phases of the WISE study, it was discovered that women are more likely to suffer from a unique form of coronary disease that affects the small coronary arteries and arterioles. This disease is called coronary microvascular disease, or CMVD. Unlike male pattern coronary artery disease, CMVD cannot be detected on an angiogram. Here, you can see a comparison of male pattern large vessel disease and female pattern small vessel disease. It is plain to see that we are not comparing apples to apples here. Instead, we are looking at two distinct disease processes, each of which demands a different approach to diagnosis and treatment. Before I go on, I must stress, however, that despite these gender trends, women can have large vessel disease, and men can also have small vessel disease. Several traditional diagnostics for coronary artery disease are not as effective at detecting coronary microvascular disease. Such diagnostics include exercise stress tests and coronary angiography. In addition, the normal values of certain diagnostics may be different in women, though this hypothesis is still under investigation. So, what diagnostics can practitioners use to detect female pattern heart disease? Currently, the gold standard for diagnosing CMVD is coronary reactivity testing, or CRT, which is pictured on the right. However, this test is invasive and involves exposure to radiation. There is also a novel diagnostic test on the horizon, cardiac MRI. CMR is a very sensitive test, and it is able to examine the perfusion of the smallest cardiac vessels. Here's an animation of how it works. If you look carefully, you can see an area of blushing at the end of diastole in the apical area of the heart. This is solid evidence of the elusive microvascular disease. This patient from Cedars-Sinai Heart Institute was actually having an ST elevation myocardial infarction, but did not have any blockages of her major coronary arteries. An additional benefit to CMR is that it does not expose patients to any radiation. While CMR is not yet widely available, it is possible that in the future it may become standard of care when microvascular disease is suspected. The good news about microvascular disease is that its modifiable risk factors are similar to coronary artery disease. Therefore, the primary concern with all of our patients is to promote a healthy lifestyle. This includes smoking cessation, regular exercise, weight control, limiting or eliminating intake of saturated fats from things like red meat, limiting alcohol consumption, eating lots of green leafy vegetables, fruits, nuts, and grains, and keeping stress at a manageable level. If preventive measures were followed more often, the incidence of cardiovascular disease would drop drastically. However, this is not yet the case, so medical interventions remain necessary. Some traditional medical treatments have proven to be ineffective for microvascular disease. One obvious example is stenting, as it is not possible to catheterize the small coronary arterioles. Another suggested treatment option was the use of hormone replacement therapy to reduce the risk of heart disease in postmenopausal women. This possibility was hypothesized due to the increased incidence of coronary artery disease in postmenopausal women. However, after investigations by the WISE study and several others such as the Heart and Estrogen Progestin Replacement Study, or HERS, it was found that while hormone therapy does help with menopausal symptoms, it does nothing to prevent cardiovascular disease and may actually increase cardiovascular risk. Despite the aforementioned obstacles, there are medications that are effective at treating microvascular disease. These include nitroglycerin, statins, ACE inhibitors, aldosterone blockers, phosphodiesterase inhibitors, such as sildenafil, and the anti-anginal ranolazine, which actually works better in women than men. An important consideration in the assessment of women at risk for heart disease is that when women experience myocardial infarction, they may have more subtle symptoms than men, such as feeling like they're coming down with the flu, and vague symptoms such as fatigue and malaise. Women are also more likely than men to have back pain in the setting of an MI. This subtlety demands focus and attention and may require a nurse to advocate for the patient if other members of the healthcare team do not have MI on their radar. It is also important to keep in mind that when women experience MI, they tend to have a poorer prognosis than men do. They are more likely to die, more likely to have a second MI, more likely to have a silent MI, and when they do receive interventions such as CABG or angioplasty, they are more likely to die than men. The bottom line is, time is muscle. So if you suspect something just isn't right, don't wait for your patient to exhibit more dramatic symptoms. This simply may not happen before it's too late. Several risk factors for cardiovascular disease are the same in both women and men. However, certain of these risk factors actually pose a greater threat to women. For example, diabetes poses a very high risk for heart disease, and that risk is actually 3 times higher in women than men. Compared with women who don't have diabetes, women who have diabetes are 4 times as likely to develop heart failure. All of this may be due in part to the fact that if women have diabetes, they are also more likely to have the coexisting risk factors that comprise metabolic syndrome X. Everyone knows smoking is bad for your heart, but please let this sink in for a minute. Smoking is associated with half of all coronary events in women, and the risk is increased even in those who smoke minimally. Smoking is another risk factor that is thought to have more harmful impact in women than men. For example, the risk for MI may actually be twice as high in female smokers than in male smokers. In addition, smoking actually has an anti-estrogenic effect, so it carries a particularly high risk in young women. This risk is greatly exacerbated by the use of hormonal contraceptives. Race is another important issue in heart disease. Heart disease, especially hypertension and stroke, disproportionately affects African Americans. In fact, 49% of African American women over age 20 have heart disease. Hispanic women are also likely to develop heart disease 10 years earlier than Caucasian women. One cardiovascular risk factor which may be overlooked is systemic autoimmune disease. These diseases occur in both genders, but several of them, such as lupus and rheumatoid arthritis, are more likely to occur in women. All patients with these conditions should receive cardiovascular screening. There are also several risk factors which are unique to women, such as pregnancy, the use of hormonal contraceptives, polycystic ovary syndrome, and postmenopausal status. Pregnancy causes many changes to the female body, which can contribute to the risk of developing cardiovascular disease. In 2013, studies performed in California revealed that heart disease is the leading cause of women's pregnancy-related deaths, but only 6% of these women had been previously diagnosed with heart disease. Conditions of pregnancy which pose a risk for cardiovascular compromise include preeclampsia and eclampsia, peripartum cardiomyopathy, and amniotic fluid embolism. Cardiomyopathy may cause up to 2/3 of cardiovascular-related deaths during pregnancy, and preeclampsia is associated with a 3 to 4-fold risk of developing hypertension after the pregnancy is over. It also causes a 2-fold risk of subsequent ischemic heart disease and stroke. Pregnancy may also exacerbate pre-existing conditions such as valvular heart disease and hypertension. Women with heart disease who are or who wish to become pregnant require close monitoring and a lot of education, but many can still have a safe pregnancy if their condition is well controlled. That said, for some conditions such as pulmonary hypertension and severe heart failure, pregnancy may impose too much of a risk for both mother and baby. In women of childbearing age, always assess their cardiovascular risk factors and encourage them to talk to their doctors about their specific situation when considering pregnancy. The last item on this list is postmenopausal status, and as mentioned earlier, estrogen has a cardioprotective effect. As such, our postmenopausal patients require a great deal of education and prudent cardiovascular assessment. Now let's discuss some of the main challenges we face in the fight against heart disease. One major obstacle is lack of awareness, both among lay people and the medical community. The American Heart Association has been studying heart disease awareness since 1997. At that time, only 30% of women knew that heart disease was their leading cause of death. In 2012, that number had climbed all the way up to 56%, thanks to the efforts of numerous awareness campaigns, such as the National Institutes of Health's The Heart Truth and the American Heart Association's Go Red for Women. While awareness has nearly doubled in the last 15 years, 56% is still only about half of all women. So there's a lot of work to do in terms of public awareness. Additionally, in specific minority populations, awareness is even lower than the overall average. Only 36% of African American women and only 34% of Hispanic women identified heart disease as their greatest threat. Lack of awareness also extends into the medical community. In 2005, a special report in Circulation stated that fewer than 1 in 5 surveyed physicians were aware that more women die than men each year from cardiovascular disease. I did not encounter any comparable study involving nurses, so this is an important area of research to consider pursuing in the future. A recurrent theme in the setting of atypical or vague symptoms is that either patients, medical professionals, or both suggest that these symptoms are actually attributable to stress and anxiety. In listening to the stories of heart disease survivors, I have even heard these women say that they felt like they sounded crazy for insisting something was very wrong. Simply put, shrugging off potentially life-threatening symptoms is unacceptable practice, and doing so may cost women their lives. Another obstacle is underestimating the value of prevention. According to the American Heart Association Nutrition Committee, nutritional management is a keystone strategy in the prevention and possible reversal of cardiovascular disease. You can see the effect of nutritional intervention in these images on the right of your screen. These images were taken from a 2001 Cleveland Clinic study and show the left anterior descending coronary artery of a patient before and after a 32-month-long plant-based diet. Non-compliance with prescribed therapy is another major obstacle, but nurses can help to improve compliance through respectful and compassionate communication and by providing effective education. Women tend to put others before themselves. When heart disease survivors tell their stories, they often state that they realized something may have been wrong, but they put their own needs aside in order to care for their loved ones or perform their jobs. I always like to confront this issue with an analogy brought to us by the heart itself. The heart is responsible for delivering oxygen and nutrients to the entire body, and we depend on it for our well-being and survival. However, before it takes care of everything else, the heart first pumps blood to itself. If the heart did not commit this anatomical act of putting itself first, it would be of no benefit to the rest of the body. So in light of this, I ask that you all put yourselves first and encourage your patients to do the same. There are several key nursing interventions to support women with cardiovascular disease. These include advocating for your patients by using respectful and open communication with the healthcare team, helping your patients to meet their physical and psychosocial needs, looking out for the classic and atypical symptoms of heart disease, paying close attention to those at risk, promoting awareness of women's heart health to members of the healthcare team, and informing your patients of their individual risk factors and how to improve those that are modifiable. Finally, a very important nursing intervention is to follow your heart. If you sense that something just isn't right, say something. You may save someone's life. So here is where we left off in our timeline of cardiovascular mortality. And here is the vast improvement achieved by 2010. Thanks to advocacy, awareness, and major medical breakthroughs, the quality and effectiveness of care for women with heart disease has drastically dropped the mortality rate. As the nurses of tomorrow, we can make a difference in the fight against heart disease. Through education, advocacy, and by following our hearts, we can create a positive impact for our communities and stop heart disease in its tracks. Thank you for listening. For more information, please visit njnsinc.org.